In this lecture, we will be continuing our discussion of Chapter 8, moving into rehab facilities prospective payment systems in the inpatient setting. Inpatient rehab facilities, or IRFs, provide intense, multidisciplinary services to inpatients. The purpose of these services is to restore or to enhance patient's function after either an injury or an illness. Members of the team that provide care could include physicians, nurses, physical therapists, occupational therapists, and maybe even speech therapists. The services should be medically necessary, should be based on an assessment, and also individualized for each patient's unique needs. IRFs must be licensed under applicable state laws in order to provide skilled nursing care to patients 24 hours out of each day. The facilities can be freestanding hospitals or maybe just a distinct specialized rehabilitation unit within an acute care hospital. Medicare accounts for approximately 60% of inpatient rehab facility cases. In 2010, there were about 1,180 Medicare certified IRFs. Medicare beneficiaries' inpatient rehabilitation hospitalizations are covered under Medicare Part A. Pre-admission screening establishes a Medicare's beneficiaries' eligibility for the inpatient rehabilitation. In order to be eligible for treatment in an IRF, a beneficiary must be able to tolerate and benefit from 3 hours of therapy per day or 15 hours per week, and that would be 7 consecutive days. So therefore, there really is relatively few Medicare beneficiaries that use services in an IRF. Medicare beneficiaries admitted directly from an acute care inpatient hospital do not pay a second inpatient deductible. That IRF admission is part of the benefit period, and we talked about that in Chapter 4. However, Medicare beneficiaries who are admitted from the community are beginning their benefit period and then therefore have to pay the inpatient deductible. The Balanced Budget Act of 1997 authorized the development of the Inpatient Rehab Facility Prospective Payment System, or IRF PPS. In January of 2002, CMS implemented this prospective payment system. This implementation did include the amendments to the IRF PPS from the Balanced Budget Refinement Act of 1999 and also the SHIP Benefit Improvements and Protection Act of 2000. To be classified as an IRF under the prospective payment, too many acronyms here. A facility must meet a compliance percentage. That percentage is the minimum percentage of an IRF's inpatients requiring intensive rehab services in a certain number of qualifying conditions, which we'll look at on the next slide, and that includes comorbidities. These are the 13 qualifying conditions that we talked about in the previous slide. Certain healthcare organizations are excluded from the IRF PPS. Those include VA hospitals, hospitals that are reimbursed under state cost control systems or demonstration projects, or non-participating hospitals furnishing emergency services to Medicare beneficiaries. And today there are about 1,200 Medicare certified inpatient rehab facilities. CMS does require that inpatient rehab services be reasonable and medically necessary for each Medicare beneficiary. Those requirements, which we call coverage criteria, include documentation of a pre-admission screening, close medical observation, a director of rehabilitation must be on staff, the plan of care, and they must also have a coordinated multidisciplinary team approach. The time frames in the coverage criteria do not affect the time frames for the inpatient rehabilitation facility patient assessment instrument, or the IRF PAI. And here is that PAI that I was just referring to on the previous slide. That features an 85-item tool, and that tool collects the information that drives payment. It must be completed on both Medicare Part A fee-for-service inpatients and also on Medicare Advantage or our Part C inpatients. It must be completed for each Medicare patient 2 times, on admission and again at discharge. The PAI does consist of 9 different types of patient information that is collected, and that is listed here on the slide. By the 4th day of admission in an inpatient stay, the IRF PPS is required to have assignment of codes at this point. The codes reflect the reason for the admission, the etiology of the impairment, NRCCs, complications and comorbidities, and the reason for transfer, interruption, or death. The functional abilities of the patient must be assigned using what is called the Functional Independence Assessment Tool. The codes that are on the PAI, those are used for research, for grouping patients, which we'll talk about a little bit later, and for determining what payment tier that the patient falls under. Which should be noted here that the codes on the PAI do not follow the UHDDS and the UB04 guidelines. And more talking about our codes, that reason for admission is coded using an impairment group code or an IGC. CMS does provide these codes in a manual, and there are 85 IGCs. The IGC structure consists of a 2-digit number, a decimal point, and 1 to 4 digits representing subgroups. Basically, that code describes the primary reason that the patient is being admitted to the rehab program. A comorbidity is a specific condition that the patient had at admission to the IRF. So they had it before they came in. Complications, those are comorbidities that occur after they have been admitted. So they did not present to the facility with that condition. It developed after admission. Some comorbidities and complications affect a patient's care in addition to what impairments they came in with. For these CCs, the IRFs must use additional resources, which equals cost, in order to treat these patients. To account for these additional costs, the ICD-9-CM coding of CCs is critical. Complications are reported as comorbidities in order to be taken into account in the payment system itself. Codes identified the day prior to discharge or the day of discharge are not recorded. Up to 10 ICD-9-CM codes for comorbid conditions and complications can be reported on the PAI. About 980 comorbid conditions do affect the payment. These comorbid conditions are divided into tiers by associated costs. Medicare has linked ICD-9 codes into respective tiers. Tier 1 is high cost, Tier 2 is medium cost, and Tier 3 is low cost. So this is an example of one of the tiers. Conditions that are inherent to a specific rehab impairment category, or RIC, those are excluded from the list of relevant comorbidities. So excluded comorbidities do not affect relative weight, so therefore do not affect payment. No procedure codes are reported on the PAI. The reason for transfer or death is reported by an ICD-9-CM code on the PAI. Another major element of the PAI is the Functional Independence Assessment Tool. This tool is an 18-item rehabilitation-specific instrument that reflects the characteristics of patients. It captures patients' functional status. Functional status, that is the patient's ability to perform activities of daily living. CMS has organized this assessment by both motor and cognitive functioning. The tool was developed in the 1980s, and about 75% of IRFs do use this instrument to measure the severity of a patient's impairment. The 18 items are measured on a 7-level scale that classifies patients according to their ability to perform certain activities. A score of 7 would indicate complete independence, where a score of 1 would indicate complete dependence. So therefore, a higher score means the patient has more functional abilities, and a lower score would mean the patient has fewer functional abilities. IRF staff members must complete PAIs upon admission and then again at discharge, as we already discussed. The PAI must be completed within specific time frames. However, if entries are incorrect, facilities may update data at any time prior to the transmission of that PAI. Facilities must submit the PAI to CMS electronically. The data must be encoded using CMS's free program, which is Inpatient Rehab Validation and Entry, or IRVN software. There are strict time frames for submission. Failure to follow those would result in a 25% reduction in payment. So there's really an incentive to have those done on time. The prospective payment system for IRFs is based on classifying patients into groups with similar characteristics These groups account for variations in the use of resources to care for and provide therapy to the patients. So the steps listed here, we will go into a little bit further in the slides, but you can read through those on your own. A standard payment conversion factor, or our base rate, converts the CMG weight into a payment. The standard payment conversion factor covers all operating and all capital costs that an IRF would be expected to incur while providing intensive rehab services. These are updated each year to reflect the market basket and the mix of patients. The prospective payment system does take into account geographical factors through the adjustments of local wages. The case mix adjustment accounts for the use of resources related to patients' differing conditions and statuses. The adjustment for wages, that's that labor-related share, and the non-labor-related portion represent geographic adjustments. There are two wage-related adjustments. The first is the labor-related share. The second is the wage index. Each year, the ratios of the labor-related share and non-labor-related share do vary slightly. A special case mix classification was developed unique to inpatient rehab facilities. This special case mix classification was specifically developed so that IRF PPS could be implemented. This classification accounts for the variation in resource use across patients in all rehab facilities. The classification is called case mix groups, or CMGs. CMGs, those are classification or classes of patient discharges from IRFs. These groups represent similar function-related discharges based on impairment, capability of the patient, age, and those CCs. There are 100 CMGs, 95 are clinical, and 5 are administrative. CMGs are 4-digit codes. An example would be 5104. CMG is derived from the rehab impairment category. The total of motor scores from functional independence assessment tools are included, as well as the total of cognitive scores from the functional independence assessment tool. Age, and as I said, comorbidities are included in the CMG determination. In the admission assessment, patients are assigned to one of these 95 CMGs. Patients are classified into CMGs based on admission data, clinical characteristics, and the expected improvement of the patient's functional status as reflected in the Functional Independence Assessment tool. A grouper is used to classify patients first into one of the 21 RICs, and then the RIC determines the final CMG. As I said, the CMGs are 4-digit numbers. This is an example of how relative weight would be affected by the different level of tiers. The remaining 5 administrative CMGs are for case level adjustments. There is one CMG for short stay cases. Short stays comprise 3 days or less and do not meet the definition of transfer. There are also 3, facility level adjustment factors. Rural location is one. CMS defines rural as being outside of an urban area. So to increase payments to our rural IRFs, their payments are multiplied by a rural adjustment. CMS does periodically recalculate that rural adjustment. The next is share of low-income patients. CMS does increase payment to IRFs that treat a high percentage of low-income patients. And finally, teaching hospital adjustment. Teaching IRFs do receive an adjustment for the additional indirect cost of providing medical education. In the IRF, the unit of measure of the system is the discharge. CMS reimburses IRFs for each discharge, with all costs covered, inpatient services included. CMS's Pricer software does calculate the payment. Finally, if two applicable outlier calculations, two of them could possibly be applied. One is high cost and one is short stay. High cost, if it's 80% of a difference between the estimated cost of the case and the fixed loss threshold. And short stay, those are less than 3 days. The CMI, or the case mix index, is a sum of all relative weights divided by the number of cases in that period. If it's lower, they are getting less money. If it's higher, that means there is an increased complexity. So then we have the sum of all relative weights, just as an example there, and the number of patients in the period. And you can see what the final case mix index would be. Comprehensive and accurate coding and reporting of all the items on the PAI are essential to getting the correct Medicare payment. Documentation in the patient record should support all of the IGC and the ICD-9 codes assigned. Both paper and electronic formats are acceptable. Electronic is preferred. Medicare Part A says the IRFs must maintain the PAIs for 5 years. For Part C, it's all those within the past 10 years. The Balanced Budget Act of 1997 authorized the development of a prospective payment system for IRFs. These facilities may be freestanding or located within an acute care hospital, like we discussed earlier in the lecture. The minimum percentage of patients must have a qualifying condition. Again, those are listed earlier in the slides as well.